So I'm going to talk about a couple things today, a couple common hand problems. I'll talk about a little bit of arthritis, some thumb arthritis. I'll talk about carpal tunnel syndrome, and I'll also talk about distal radius fractures. Those are three kind of bread and butter problems that people have. If you guys have any questions or any specific things you want to talk about, I'll be happy to.
Not a problem.
Happy to talk about them, okay? And interrupt me as I'm going through this. If you can't hear me, I tend to mumble. And if something's not clear or you don't understand anything, feel free to ask questions, okay? Adam Fleit, yep, that's me. I know, that's a bad picture. All right, so let's start here. So this is the outline. Just went over some of the stuff I just talked about. So thumb basilar joint arthritis, that's the first thing we'll talk about. You have your splint on there. That's a good example of one of the treatments for that. Carpal tunnel syndrome, and then distal radius fractures. All right, so we'll start with the thumb here. So base of the thumb arthritis, and that ends up being arthritis right here. And that's where a lot of people have pain when they have it. It's a very, very common problem. It affects women more than men, but it's not uncommon for men to have these kinds of issues, okay? Usually over the age of 50, if you're younger than that, if you have this problem, it tends to be associated with a trauma, or if you had a fracture into the joint itself and the joint was stepped off, and that can accelerate arthritis. People who are younger tend to have that kind of problem, or they're just unlucky in terms of their genetics. And it's not just this joint that's involved, the CMC joint, it's also this joint can get involved too, your metacarpal phalangeal joint, okay? And we'll talk some more about that. So first of all, so what is arthritis? That's a question I ask patients a lot, and a lot of people don't understand exactly what it is. And so arthritis is loss of cartilage at the joint. So when you take apart a chicken, whoever's done that, you open up the joint, at the leg where it meets the body, and you see that joint there, and it has that cartilage on top. Now, all of our joints look like that. And when we're born, all of our joints are super smooth. It's just like a newly paved road. And sometimes as we age, for various reasons, you can get potholes in the road, okay? And that's essentially what arthritis is. It's loss of cartilage over time. And as that happens, your body reacts in a very specific way. The capsule around the joint gets thickened. And you also get these osteophytes, which are essentially bony mountains that develop around the joint. And the goal of the capsular thickening and the osteophytes is to limit motion. So your body is not dumb. If you have two surfaces that are no longer smooth and it hurts when they rub against each other doing certain movements, your body works to try to limit those movements. And that's one of the ways you can adapt. And it's not uncommon for patients to come to the office and say, oh, I slipped and fell and now my thumb hurts. And I say, well, you have arthritis. And they say, no, I hurt myself. I said, no, you have arthritis. What happened was your joint just moved in a way that it wasn't supposed to, and it exacerbated the pain. And so arthritis is a process that takes a long time to develop, and a lot of people have it before they're symptomatic. Okay, and so it's not unusual for those kinds of things to happen.
Most of the time, the arthritis can set in after serious injury?
Sometimes, yes. So sometimes you can have arthritis. So you can have arthritis for lots of different reasons. Osteoarthritis is the most common form, and it's a multifactorial cause for that. And so it's partly genetic. Some people are prone to degenerating their cartilage. It's also with use too. And so if you're one of those unlucky people who has the genes that are predispose you to having osteoarthritis, and use your hands a lot, you're going to get arthritis early. And so other reasons to have arthritis, you can have inflammatory arthritis. So an inflammatory arthritis is like rheumatoid arthritis. Lots of people ask about, do I have rheumatoid arthritis? So rheumatoid arthritis is a very different form of arthritis than osteoarthritis. So rheumatoid arthritis is when the body attacks itself. You have inflammatory tissue that goes wild, and it degenerates the cartilage, and it's characterized by bony erosions. And you can see the joints get absolutely destroyed with runaway rheumatoid arthritis. But osteoarthritis, joints, not until late stage do the joints get kind of really blown up. Usually they maintain their architecture. And like you said, trauma, is another reason to have arthritis. So if you have a big high energy injury where the fracture goes into the joint and the cartilage gets damaged, that can accelerate arthritis. Or if the joint surface is blown up into lots of little pieces, you can't really put that back together the way it was, and so you put it back together the best you can, but sometimes the surfaces are stepped off, okay, and then they start moving when you start moving your body, and that can accelerate wear because the surfaces that are supposed to be smooth next to each other aren't, and so you have abnormal contact pressures. So there's lots of reasons to have arthritis, but the general thing about what arthritis is it's loss of cartilage. Okay. Oh, sorry about that. So thumb anatomy. So for base of the thumb arthritis, this is the area that we're talking about, right there. So right here. So right at the base of your thumb. Yep, right there. Right where your thumb meets your wrist.
I'm having a problem here. Over here.
On that guy?
Not here at all.
Not there at all?
All here.
Yep.
And right here.
Yep. Sometimes you can have arthritis. There's lots of reasons for that. So when you get arthritis here, sometimes you have limitations in your thumb motion. The motion of your thumb, your ability to move your thumb in this plane of space, the vast majority of that motion comes from your CMC joint. That's the base of the thumb joint, okay? This joint here, it moves very little. I don't know, mine moves maybe 30 degrees. Some people are very flexible. This joint can flex almost to 90 degrees, but mine flexes very little. And you get some motion from this here too. But that's something a lot of people don't realize. This joint is the most important one for thumb motion. And that comes into play for deciding how to treat this problem. So here's an x-ray of a hand. Let me grab a pen here. And so the joint that's the joint right there.
Oh, I'm sorry.
That's the thumb CMC joint. So carpo wrist, metacarpal joint. This is your metacarpal phalangeal joint. So this joint is right here. And this is your interphalangeal joint, and that's right there. Okay? And sometimes when you get bad arthritis here, you have a deformity, which I'll identify later, and that can cause this joint to act up too, and you can get arthritis there. Okay? So symptoms. Most commonly, patients complain of pain right in this area. And they also complain of difficulty with opening jars, opening doors, pinching firmly.
Holding things.
And sometimes people have trouble sleeping. It hurts so much that it keeps them up at night. And also, some people can get a big bump over here because of the way this metacarpal bone will move as a result of the arthritis.
I was going to say, isn't that when it starts turning to rheumatoid?
Nope.
The nodules?
Nope.
That's not rheumatoid nodules?
No, not what I'm describing here. This is just a bump on the side of your wrist here because the joint's essentially dislocating.
Oh, just on the joint?
Just on the joint. Yeah, I'll show you. So here's a picture of that. So I want you to pay attention to this and notice, see this big bump right there?
Oh, yeah.
And then this bump right there. And if you look at my hand, I have it a little bit, but not too much. And so what happens with this is this metacarpal bone, instead of being out like this, it tends to go in like that and get contracted there. So it gets stuck inside your palm. Now, you hold your finger like this, your thumb like that, in. You can't grab anything like that. It's really difficult, right? Because your thumb is stuck in your palm. And so what your body does to compensate for that is it allows this joint to start to hyperextend so you can clear the rest of your thumb out of your palm so you can grab stuff. And you can appreciate that with right here. This is that metacarpal phalangeal joint. See how much you can bend it? I can't do that at all. Mine goes maybe 5 degrees, maybe, and that's pretty much normal. hers right here, that's maybe 40 to 50 degrees of hyperextension. Okay, and that comes into play when you take care of this with surgery, because one of the goals is to rebalance the thumb. So you want to try to take the metacarpal out of the plane of the hand here, bring it out, and then if this joint still has a tendency to hyperextend, if you don't address that, you can kind of lose that balance and the thumb can drift back in. So here's an X-ray. So I want to go back to this picture here. So this is what a normal joint looks like. See how there's a space between these two joints there? And compare it to this X-ray here. See how there's no space between these two joints?
Bone on bone.
Yep, bone on bone. You see this big bony bump right there? That's an osteophyte. That's that bony mountain that I described before. Can you guys see?
Osteo.
Yep. And this is typical of osteoarthritis. You can still make out the bones. The bones were not eroded away. They're not destroyed. You can still make out the architecture of a joint. It's just there's no space between them anymore. And if you look at this joint right there, that's what a normal joint looks like. That black space represents cartilage. You can't see cartilage on X-ray because it's not calcified. But you can see that black space there. And this X-ray also is telling about part of the mechanism for why people develop arthritis in this joint. Osteoarthritis, that's what we're talking about here. It's a multifactorial thing. Genetics comes into play. Activity comes into play, as I mentioned before. But for this kind of arthritis, what also happens is the ligament that holds this bone in place tends to wear out over time. And it's a slow wearing out. And this bone starts to slide out. Okay, and that's why you get that bump over here, because the bone is literally kind of slowly dislocating out of the joint because the ligament just can't hold it in place anymore. And you can't tell this on this X-ray, but the shape of this joint, it's two saddles rotting each other like this. Okay, it's a very, very, very specific shape with very low tolerances. Now, if you can imagine, if they're out of whack, now all of a sudden you have a sharp edge riding on an edge that doesn't match up to it, and you have these abnormal contact pressures on the cartilage and it can start to wear away. Imagine if it was just two flat surfaces, right? It slides out, who cares? There's still two flat surfaces and they still match up, but if the surfaces don't match up, they can start to rub abnormally. And this is the, and this is the result here. Sometimes also, this joint here can be involved. This is called your scaphotrapezoid trapezium joint. That joint can also be involved as well. So treatment, there's non-operative treatment and there's operative treatment for this problem. So non-operative treatment, so bracing is an effective initial treatment. So she has a brace on now. Yeah, but that's also a very similar brace that right here that sometimes people use to immobilize the thumb. A fair number of patients don't like the rigid braces because they immobilize your thumb and they don't find them very functional. This is an option as well for that. This is a soft brace that helps to basically just hug your thumb and allows you to actually do stuff, to be functional with it. And sometimes your occupational therapist can help you, kind of parse out the braces. So bracing is one treatment. Another treatment are steroid injections. So these are anti-inflammatory steroids. They're not anabolic steroids. So anabolic steroids are the ones that bodybuilders use to build their muscles up. Steroids are, anti-inflammatory steroids help to decrease the inflammation within the joint. And it's an absolutely worthwhile thing to try at least once, okay? Because it's low risk, it has very few side effects, and it can be a great benefit, but sometimes it's not. Everybody responds a little bit different to steroids. Sometimes it might be a week of relief, might be a day of relief, and sometimes it might be a year of relief. You have no idea. But it's certainly an easy thing to do, and it's worthwhile trying it. Okay, and you can get those injections every couple of months if you need them, but it's usually diminishing returns. You know, the more injections you get, the shorter duration of relief you get. Okay, but sometimes it can be for a while. So in general, with injections, like I said, it's about 3 months. So outside of medications, activity modification, steroid injections, bracing, there's very little other options available. And some people can get by with doing that. A lot of times activity modification is what patients tend to do the most, and they don't even realize they're doing it. If something hurts, they just stop doing it. But sometimes that can limit what you do. You know, if there's something you really enjoy that hurts, you know, when you stop doing it, some people sort of say, oh, well, I can't do that anymore. You know, some people don't, but you know, activity and modification is a big part of how you can kind of self-treat. So, in general, there are 3 types of operations for this problem. So, surface replacements, where you take a piece of metal or a metal and plastic and you resurface the joint. It's much like it's very similar to having a total hip or a total knee done. Those are an option. I'll talk about that. Ligament reconstruction and tendon interposition with removal of the trapezium bone. So that's the tried and true operation. That's the one that's been around the longest. It's sort of the gold standard, and it's the operation that all the other kinds of surgeries are trying to beat. Okay, that's the surgery I do the most often for this problem. And another option is a joint fusion between the metacarpal and the trapezium.
That's when the wrist is straight?
Nope.
Fuses?
Yep. So that's just for this joint. So you fuse between the metacarpal and the trapezium. You'd still have wrist motion.
But you wouldn't here.
Not there. You'd be able to bend this joint and that joint. As I said before, most of your thumb motion comes from this joint. So fusing that's really for a very specific patient population that I'll discuss later. But your thumb is essentially stuck like this. You can't move it around. But some people might find that a benefit, okay? So ligament reconstruction, tendon interposition, this is the tried and true operation. So what this surgery involves, so it has the longest track record. It's very reliable. The advantages are it's good pain relief, and it maintains the range of motion of the thumb. Disadvantages are loss of pinch strength. You know, so when you remove the bone there, you're removing the fulcrum that you can pinch against. Okay. By the time patients are ready to have surgery, it's so painful to pinch that when the pain's gone after the surgery, they actually feel stronger because it doesn't hurt when they do things. But if you actually measured it, their pinch strength tends to go away. So this is kind of a picture, an artist's rendering of what the surgery entails. So here's that arthritic CMC joint right there. This is the trapezium bone, and you remove that, and that leaves a void that you have to reconstruct the suspension system for the joint. Here's that trapezium bone gone, and so this is your flexor carpi radialis tendon, and when you're doing the surgery, the incision's right there. And once the trapezium is gone, you can see that tendon right in the base of the wound. So you can cut it here and then pull it out here, right through the base of the wound. You can take it, you weave it around the metacarpal, and that helps to suspend the metacarpal, right? Because without that restraint, the metacarpal will just subside into the hole, okay? Where that bone used to be. And take the remainder of the tendon, you ball it up into this anchovy, and you place it into the void where the trapezium used to be. You close the joint capsule around it, and as you heal, this tendon, along with the blood clot that develops in there, turns into a fibrous scar ball, and it's basically a cushion for the joint. You know, and in order to get the thumb into a good position, you have to go through a period of immobilization. So it's basically 6 weeks. Either first 2 weeks you're in a splint, which is essentially a cast, but it allows for some swelling, and then the next 4 weeks you're in a cast. So it's about 6 weeks total of immobilization, and it's molded in a very specific way to hold your thumb in a good position so that everything sort of stiffens up and heals up. And then the cast comes off, then you go see the occupational therapist, and you have a splint put on that you take on and off, and you start with range of motion of your thumb. And then at 3 months you can start strengthening. So this is a long process, right? Yeah. So it's a long process to go through for this. So, and it takes about a year for your thumb to start to feel like it's yours again, to develop your strength. So it's a while. Not always, sometimes less. But again, people who opt to have the surgery, they're miserable. Their thumbs kill them, they can't do much of anything. And so it's worth it to them to go through this process and heal. And it's not like your thumb's useless for a long time. It just takes some time to develop the strength back again. All right, so this is an example of a bony fusion. So here's the trapezium bone, and here's the metacarpal, and you can see how they're united into one bone, and there's this plate and screw construct holding it into place. And the purpose of the plate and the screw construct is to hold the bones in a good position so that they heal. This surgery is a very durable operation, okay? It will stand up to a ton of stress. The problem is you can't move your thumb very much. So the patients who tend to opt for this are those that are maybe younger and are in a very high demand labor field, like they're a construction worker or they're a jackhammer operator or something like that. But the downside is your thumb is like this all the time. So it's optimized for grabbing things and pinching, and you still have, it maintains that strength, right? Because you still have a forceful or a nice fulcrum to pinch against, but your motion's not there. You have trouble putting your hand in your pocket because you can't put your hand flat. Your hand's always like this. So the disadvantages of this is that this is a very, very, very high stress area, and these two bones want to pull apart like this. Okay, and so, and this trapezium bone is pretty small, so there's not a lot of bony surface there, and there's not a lot of surface for you to get fixation into with your screws to hold the things in place. And so there's a tendency for this fusion site to not heal, which is called a non-union, which means that's when two bony surfaces that are meant to heal don't heal. And so that can be a complication from this. And because it's so high stress, it's prone to that happening. Yes, sir.
Why would you want to do that rather than the second surgery you mentioned, the ligament reconstruction and so on?
So the ligament reconstruction tendon manipulation allows for motion, but if you're going to be, doing heavy labor, I mean like heavy labor,
Okay.
you can potentially wear it out
Because you
and beat it
mentioned all
up.
the downsides of it.
Yeah.
I wondered, well, what the-
Yep.
So with the ligament reconstruction, your thumb would never regain the strength needed for heavy labor?
No, it would. You'd be able to do it. You'd have to modify what you do. It might not be as strong as it used to be, but you certainly can, over time, build it up so that you can do it. But you might have to wear a brace like she has on when you do it. You might have to, kind of adjust how you do things. Use more, my dad calls them workshop helpers, like grip things and other stuff like that. But again, remember, when you're at that point to have surgery, especially people that are heavy laborers, they tend to wait forever. They can't do anything anyway. It's not like you're going from a normal thumb to having it reconstructed. You're going from a thumb that hurts a lot, you can't do anything, or you can't do many of the things you want, and you're looking for pain relief with the activities that you do. So you're willing to accept that modification and changing things up a little bit. And so this is a surface replacement. So the holy grail for this problem in terms of surgical solution is one that maintains motion, one that provides a firm fulcrum against for pinch, so you can maintain your normal strength, and is durable. Okay, and there are tons of these different kinds of implants. So this is a pyrocarbon implant. You can't, in real life, it's like this shiny black stuff. It looks like onyx. And this is a cobalt chrome implant that mimics the normal shape of the trapezium. And both of these implants just resurface the metacarpal side of the joint. The other side of the joint is left alone. And there are lots of other kinds of variations on these implants. But the problem with them is that, one, they don't work great, and two, they fail very quickly. So these are not implants that are really ready for prime time. We're talking high percentage failure, like 50% failure rate at 2 years. That's atrocious. When you look at other operations that are more durable and last a lot longer. When I was in fellowship, one of the people I worked with did some of these, but he was studying it, and so it was an investigation to see if it was a worthwhile thing to do, which is a reasonable endeavor. But he stopped doing them because they just were not ready for prime time, unless a patient came and they were very adamant, yes, I want this, I know about it, I know it can fail, but for these reasons I want to pursue this. It's not really something that's ready for prime time quite yet. So in general, in all forms of arthritis, for the most part, there's always exceptions. The thing that dictates treatment, once the diagnosis is made, is how you feel. That's my philosophy. If you're miserable, all the other stuff, the non-operative stuff has failed, and you're ready to have surgery, then it's time to have surgery. If you're not ready to have surgery, you're not ready to have surgery. And if you haven't gone through the steps of dealing with the other stuff, you're not ready to have surgery yet. No one should tell you you need to have an operation for arthritis. There are instances where that's, it's different. Certain deformities and things can make the operation harder. So if you're leaning towards, sometimes you can be nudged just to make the operation a little bit easier, and to maximize your outcome. But really, for this thumb thing, there are very, 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 very few exceptions where that would be the case. Most of the time, it's dictated by how you feel. Okay. All right. Any other questions on that at all? Yes.
I'm curious that you haven't gone through any, how do you integrate it all with, like, chiropractors or physical therapists who take a more naturalistic approach? And I do some of that myself, and that's why, and I've also been to Dr. Waugh, who previously was at your practice and gone through a number of these things, the early pre-surgical kind of steps. But I found, I got turned on to a chiropractor who said that he treated thumb problems, arthritis in the thumbs, and I said, I'm going to give it a try before going to surgery. And I've found some good effects, actually, and I've talked to physical therapists who also do that. So the question is, I've gotten some good relief. Do you promote that at all?
Yeah, so sometimes I'll refer the patients to occupational therapy where they can teach different ways of modifying their activity when they do things. They also have a variety of braces and things to offer patients. And as far as chiropractors or naturopaths, I usually do not refer people, but there's nothing wrong with it. And people that are of that mindset, they tend to seek that out, and that's fine. If it works for you, then go for it. But I can't really speak to the efficacy of those kinds of things. And there's other medications like glucosamine chondroitin. I don't know if anybody's ever heard of that. That's along the same lines. The literature on that is, no, it's not definitive by any means. And so people ask me, I said, well, try it. Try it for a month or two. If it makes you notice a difference, keep doing it. If you don't waste your money. Because the science behind that is inexact. We don't understand how it works or how it changes the arthritis or how you feel. But if those things work for you, absolutely, do them. Anybody else have any other questions on that? Nope. No. Do you agree?
When I had my thumb problem with massage, acupuncture,
Do you find it helpful?
But doesn't last, so.
Yeah, it's to a point.
And I had 4 cortisone, those cortisone
Yep.
shots, and I won't wait
Too
that
slow
long.
for them to touch me.
Yeah,
Too many.
yeah.
Please don't touch me.
You know, but it was worth a shot. I mean, the reason you had them because you weren't ready, and you were seeing an effect, and so that's, you know, that's a reasonable thing to do. You know, and no one said, oh, you need to have no more injections. I mean, you can't have an injection once a week forever, you know, but like every couple of months you can have them. I don't, you know, that's fine. So it's all about how you feel and what you're willing to do. All right, so I'm going to jump to a completely different problem, carpal tunnel syndrome, which is, you know, very, very common. You know, yeah, lots of people have it. Okay, and so it affects all adult age groups. It's very rare in the pediatric population. Both hands can be involved. You know, I have lots of patients comment, well, I'm right-handed, but I don't know why my left hand's involved, and, you know, vice versa. You know, they say, oh, my right hand's involved. I don't know why my left hand is not involved. So there's lots of variations, and so and there's no rhyme or reason why it happens or how you get it for the most part. You know, there's a very common conception that's associated with repetitive use, you know, using a keyboard or doing certain activities. But the literature, the people who have studied this, there's really no definitive link with repetitive use. And you frankly, I see lots of lazy people who have carpal tunnel syndrome, so, you know, it's hard for me to, you know, say, oh, it's because you're using stuff. Certain activities certainly exacerbate the symptoms. There's no doubt about that. You know, if you put your hands in certain, if you put your hands in certain positions, it can come on, okay? And I can't say that it's the activity that's causing it, but it certainly can exacerbate it. It's just one of those things, what came first, the chicken or the egg, you know? So this is some anatomy of the carpal tunnel. So this is obviously a picture of your hand. This is a cross-section of your wrist right here. And so if you look at this diagram, you can see this cut here is at the level of the carpal bones. Okay, and so the floor of the carpal tunnel, and it's truly a tunnel, is formed by carpal bones, where my palms meet, and the roof is formed by the ligament. All right, and so it's a confined space. And within the carpal tunnel, 9 tendons that allow you to flex your fingers travel with the nerve. So this yellow thing here is the nerve, and these are the 9 tendons that travel with it. And if you look here, here's another example of that. And so here's the ligament, and you can see this yellow structure here. Here's the nerve, and the 9 other tendons that travel. So these blue things are supposed to represent synovium that coats the tendons. Okay, and that can be a part of the reason why people get carpal tunnel syndrome.
So the tendons are disconnected in
So-
the palm of your hand, right in here?
Yep. So the tendons come from your forearm muscles. The tendons are the ropes that your muscles attach to allow you to flex your fingers when your muscles contract. They cross here, and they're all flexor tendons, and they actually go all the way to the tips of your fingers, into the tip of your thumb.
Okay, so if anything's disconnected in here, in the palm of your hand.
Yep. So it goes all the way from here, all the way to there.
Yeah, but if somehow it get disconnected here,
What do you
would
mean?
that cause carpal tunnel?
No. So if your tendons rupture in your palm, you wouldn't be able to flex your fingers at all. I'm not sure what you mean by disconnected.
Well, supposedly they told me mine would not attach after I fractured my wrist in here, because
Your-
when they shook
yeah.
my hand, it hurt.
It hurt there.
And they said that they didn't attach, it showed on the x-ray.
Yeah, that doesn't make any sense. You can't see tendons on x-rays.
Yeah,
All you can
but
see
I-
on an x-ray is your bones. And you can make a fist. Yeah,
Yeah,
so your,
but I
so your
can't.
tendons work. So they're intact. Those comments they made you don't really make much sense, you know, based on anatomy and, you know, things like that. But your tendons are intact and they're functioning, so they're not disconnected. So the median nerve, that's the nerve here that's involved. And so what the median nerve does is it supplies sensation to your thumb, index, middle, and half of your ring finger. And it also provides electricity to power this group of muscles here at the base of your thumb. So your nerves are exactly like wires in the wall. You cut a wire in the wall, you look at it on end, it has little filaments in it. Our nerves look exactly the same. And our nerves conduct electricity. And those electrical signals are what go to our brain to tell us we're feeling something soft or hard or hot. And then your brain sends signals back to the muscles, move the hand or, stuff like that. And so when the nerves involved and get compressed, you can get irritating symptoms in your fingers. Does anybody have carpal tunnel syndrome here? Yeah. So fingers can go numb.
Oh, yeah. Elbow, arm,
Yep.
shoulder.
Yep. And sometimes you can feel pain coming up here because your nerves all start in your neck to control your arm and they traverse this way. And people experience to varying degree. So symptoms. So traditionally, patients have symptoms of varying intensity in their hand. Some people, it's very mild, their symptoms. It's occasional numbness, it's not all the time. Some people, it's crazy numbness all the time. They can't sleep, or if they do simple things, their hand goes numb, and it's like a dense numbness. It's very painful and irritating. You have to shake your hand out like this. So symptoms certainly can be associated with certain activities. So people say typing on the keyboard, when they're at work. Some people have trouble with doing their hair.
And writing.
Yep, writing, and sleeping too. Sleeping is a big problem. And the carpal tunnel has been of a long-standing duration. The muscles at the base of your thumb can actually start to get weak and it can atrophy. We have a little bit of a divot there because without the electrical signal to power those muscles, the muscles aren't being used, and so the muscles start to shrink. And what happens with carpal tunnel syndrome is that the nerve's compressed, and it's just like a hose with water, a garden hose with water running through it. So if you step on the hose, the water stops. You step on the nerve, the signal will stop going. You release the pressure on the nerve, the signal will start flowing again. You release the pressure on the hose, and the water starts flowing again. And so we don't know exactly why the pressure builds up in the carpal tunnel or what sets it off, but there's certainly an inflammatory component to carpal tunnel syndrome. The tendons swell, or the lining of the tendon itself swells to the point where the nerve gets compressed, and when the nerve gets compressed, it starts to lose its blood supply, and it gets pissed off, and it tells you, your fingers start going numb, and it's a very unpleasant feeling. And basically, it's your body telling you, move your hand, stop doing what you're doing, change the position of your wrist so that the nerve gets its blood supply back. And so what can happen over time is, people have exacerbations of numbness, where sometimes their fingers feel normal, and then they start doing stuff and their finger gets become numb again. And what happens when you have those episodes happen over time, you accumulate small amounts of damage in the nerve. And sometimes patients can get numbness in their fingers where they have this numbness all the time. Their normal is having numb fingers. And that's just their baseline. And then they have episodes of exacerbations where the numbness gets worse. And when you have that baseline numbness, that represents damage to the nerve. And that has prognosis with what to expect after surgery. Okay. The people that tend to have the numbness all the time, carpal tunnel syndrome has been with them for a long period of time. Either they just sort of ignored it and just dealt with it and went on their life, which is not uncommon. People are busy, people have stuff to do, people have to work, people own their own businesses, and they just carry on and just ignore it. I have lots of patients who just like, I don't have time for that. I need to work, I need to do stuff, which is, I completely understand that.
I have surgery to do.
Yeah, yeah. Okay, so these are some examples of how patients present. So Some patients have constant numbness all the time, which sort of indicates a long-standing problem. And then they have exacerbations where the numbness gets worse, and those are sort of the irritating symptoms are the ones that result from the exacerbations. And those are the ones that really drive patients to come to see me because it interferes with sleep and it interferes with activities. And as mentioned before, like early, some patients have episodes of intense numbness followed by return of normal sensation, or what they interpret as normal sensation, where their hand feels fine. And some patients just have constant numbness and they don't have the exacerbation. That's pretty rare. And usually those are the people who've had very, very long-standing disease where their fingers are just numb. They have trouble feeling stuff. They can't do their buttons. They can't put their pills in their pill boxes. I have one patient who had those kinds of symptoms, and he ended up having surgery. I saw him this week, and he said, I was able to put my pills in the pill box using my fingers for the first time in like 2 years. Before he just used tweezers because he just couldn't feel them. So treatments for carpal tunnel syndrome, splinting also plays a role in this. Instead of including the thumb, they tend to be rigid splints that immobilize the wrists. Those are most effective when you're sleeping. Because when we sleep, we all tend to curl up like this, and we flex our wrists, and that puts a tremendous amount of pressure on the nerve, and it closes down the carpal tunnel. Now, whether we know we do it or not, everybody tends to do that. Other people can tend to go like this. That also puts a lot of pressure on the nerve. And some people will clench their fists. Now, remember, within the carpal tunnel, the tendons that cause you to flex your fingers, they travel with the nerve. And so if you sleep like this and ball up, you're putting those tendons on tension, and they get taut, and that can increase the pressure in the canal. And so the wrist splints can help to prevent you from flexing or making that hard fist. They don't always work. Lots of people, that's usually something the primary care doctor prescribed, and that patients tend to show up. I've already done that, and it wasn't effective, or sometimes it helps, or it, sometimes it's good for maybe 5 hours of sleep. It's not uncommon for people to tell me, I try them, but at 3 a.m. I can't take it anymore. I just rip them off because I can't stand sleeping with them. Again, steroid injections also play a role for carpal tunnel syndrome.
They hurt.
Yeah, I do give them, but I won't give them for as long as I will for an arthritic problem. So with an arthritic problem, cat's out of the bag, cartilage is already gone. Having more injections, it won't really change much of anything. But with carpal tunnel syndrome, I don't like doing more than 1 or 2 injections, because if the symptoms keep coming back, those are all little damages to the nerves. And I'd hate to mask those symptoms and have the nerve be repetitively damaged, and then all of a sudden, patient shows up, their fingers are densely numb, the thumb is wasted, and they have true deficit that I can't necessarily fix with surgery. I'll get to that afterwards, okay? But a lot of times they tend to be very effective, and they do the same thing as they do in the joint. They help decrease the inflammation around the nerve, and so by decreasing inflammation, you decrease swelling, and with less swelling, there's less stuff in the canal, so you can't generate those pressures on the nerve as much. But unfortunately, the results tend to be transient. I'd have to say more so with carpal tunnel syndrome, patients more often than not really just get a couple months of relief from it, and sometimes it's a couple days. It's not necessarily permanent. Yes.
Does icing help? Because I've had periods of time when I've had a lot of pain in my wrists, and I've put them on vegetable bags, like frozen vegetable bags, and
Yeah.
it has helped to relieve the pain, because I think it's swelling too at the beginning of those type of things, right?
Yep. Yeah, icing definitely can help a lot of inflammatory conditions and make you feel better. But it certainly doesn't hurt, and it's certainly something to try. It doesn't necessarily work for everybody. Some people tell me when their hands are on fire, the only thing that makes it better is heat. So they dunk their hands into hot water from the faucet, And some people say cold makes them feel better. So people are all sort of all along the spectrum for what can help them relieve their symptoms. And frankly, people are trying anything to like get it better or make that dense numbness go away. Mostly probably because they're trying to get a good night's sleep. Occupational therapies, our hand therapists can also be helpful. They can make you a very specific splint for carpal tunnel syndrome that holds your wrist in a very specific way. And they can also show you some exercises to get the nerve moving within the canal. So that's also another treatment option. One thing I often get is a test called an electromyography. It's an EMG, and also part of that is nerve conduction studies. And a different doctor does those, either a physiatrist or...
You send us a lot of them. You send us a lot of them.
Yeah, or a neurologist does them. And what they do is they test how well the nerve is working, right? Because your nerve is just like a wire in the wall. You can take a voltage meter and put it on a wire in the wall and see how well the wire is working. You can do the same thing with your nerves. And they often grade the severity as mild, moderate, or severe. I care less about the severity, than how the patient's feeling. I see some patients come in who have severe carpal tunnel syndrome on their EMG, and they have very minimal symptoms. And I see some patients who have very mild carpal tunnel syndrome on EMG, and they have severe symptoms, and their injection didn't work, and they want surgery. And so I obviously take into effect what the EMG shows. It's a very important test to get, and it can help with prognosis and what to expect after surgery. But the decision to go into surgery isn't necessarily just on the EMG, it's also how the patient's feeling. I often will do a steroid injection in my first visit and then send the patient for an EMG and then have them come back and we'll discuss the results of the EMG. Unless the EMG has very specific findings, I won't push the patient into surgery unless the injection's already worn off at that point. And so if they're feeling good, there's no reason to take the risk because that injection might last for a year plus. And then they say, when the injection wears off, come back and see me and we can, discuss other options. One important thing that the EMG will do is it tests how well this group of muscles here is working. And so sometimes the EMGs will say moderate severity carpal tunnel syndrome with active denervation. So active denervation refers to the loss of input into this group of muscles. And so that's something that's concerning to me. And that's one of the instances where I will encourage patients to consider having surgery for carpal tunnel. And that gets to what to expect after surgery. So those patients who have exacerbations of their numbness with return to normal feeling in their fingers, they tend to do the best after surgery in terms of symptom relief. Because once you take the pressure off the nerve, you can't generate the pressure anymore on the nerve to get those exacerbations, and those almost reliably go away. Patients almost always are able to have comfortable sleep. The numbness doesn't wake them up anymore. The numbness doesn't get worse with activities. But those patients that have that chronic damage to the nerve, sometimes those symptoms will persist after surgery. So that baseline numbness, just that little bit of tingling in their fingers, or sometimes it's dense tingling, but it's just normal, it's just that way all the time. Carpal tunnel surgery doesn't necessarily fix those. What carpal tunnel surgery does for those kinds of patients is relieve the pressure on the nerve and put the nerve in an environment to allow it to heal itself. Okay, so the nerve's no longer being damaged, but now the pressure's off, and so it gives the nerve an opportunity to heal. Whether the nerve does that or not, we don't know. Nerves are very finicky things that we don't necessarily understand all the physiology behind them. And, so those patients who have baseline numbness where they're normal is numb fingers, and sometimes this group of muscles here is wasted away. Surgery will take away their exacerbations, those periods of time where their numbness gets worse, where it's real irritating and painful, and they have to shake their hands out. But oftentimes, they can still have some numbness after surgery, and it can take months for the nerve to heal. And that recovery might be complete. It might get all the way back to normal. It might be incomplete, where it's partway healed. or it might just stay the same. And so for those patients who have long-standing carpal tunnel syndrome with baseline numbness, where their normal is numb fingers, the goal of surgery is to, one, relieve the exacerbations so that you can sleep, and so that numbness doesn't get worse when you're doing certain activities, and also to preserve the function that they have, because it can always get worse. And when the EMG shows denervation here, and even if the thumb is strong, that denervation to me tells me that the nerve's being damaged and the muscle's losing input. And so if we can arrest the process right then and there when the patient has good function of their hand, I think that's a win. And so that's sort of the one time where I'll encourage patients to pursue surgery. But again, if the EMG comes back and says mild, moderate, severe with no active denervation, and the patient feels good after the injection and they're happy with how their hand's feeling, then we just leave the follow-up open-ended. And if the symptoms come back, I'm happy to to intervene at that point. Okay? All right. So surgery, so carpal tunnel surgery. So in my hands, carpal tunnel surgery involves an incision at the base of the palm here. You categorize it as a mini open surgery, a couple centimeters long, but the goal of all carpal tunnel surgery is the same, to release the ligament, okay? So again, where my palms are, that's the carpal tunnel, that's the base, those are the bones, and the roof is ligament, and so when you do surgery, you cut the ligament, and it opens up like this, and then it heals in this elongated position, so that there's just more room in the carpal tunnel, so you can't generate those pressures on the nerve anymore. And so again, just to reiterate things, those exacerbations of numbness, those periods of time where the numbness gets worse, where you have to shake your hand out like this, those very reliably go away. Patients are able to sleep at night. Their hand doesn't wake them up from sleep anymore. And when they're doing the activities that they enjoy, the numbness doesn't get riled up and prevent them from enjoying those activities.
What's the percentage of the carpal tunnel release not working?
It's pretty low. It's pretty low. So one of the problems is that if the surgeon doesn't prepare the patients for what to expect afterwards, then patients can view the surgery as a failure, and the surgeon can view it as a success. And so it's a tough question to answer. And that gets to the point what I was trying to reiterate before, is that patients who have very severe carpal tunnel syndrome of long-standing duration, oftentimes their fingers are numb forever. It's not uncommon for patients to come to see me for a second opinion and say, I had carpal tunnel surgery, it didn't work. The surgeon didn't do a good job. And I said, well, what were your symptoms before? I said, well, my hands were numb. I said, are your hands just as numb before surgery? Yes, it hasn't changed at all. They're still numb. I said, all right, well, before surgery, did you have periods of time where the numbness got worse? Yeah, I had that. Did it wake you up from sleep? Yeah, that woke me up from sleep. Did your hand wake you from sleep anymore? No, it doesn't wake me up from sleep anymore. And so the patient wasn't prepared for their fingers to still be numb. They thought, I'll have surgery, my fingers will be perfect again. So they weren't prepared ahead of time for that. And so I explain to patients that, if you have really severe disease, you won't necessarily recover the function that you've lost, but you preserve the function that you have, and those irritating symptoms, the exacerbations, they go away. Some patients have recurrence of carpal tunnel syndrome, despite a period of successful symptom relief afterwards. It's about 5% of people. Why that happens, we're not 100% sure. It has to do with how the scar matures around the nerve after you do surgery, and sometimes you can get sort of these little spot welts of scar to the nerve, and when you move your wrist in a certain way, the nerve just doesn't move with it as well as you want. And that's a theory. It's not really set in stone. Other reasons for a carpal tunnel release to be a failure, incomplete release of the ligament. The whole thing's not released. There's a little band that's still left that got missed, and your symptoms can persist or sometimes be worse. And sometimes the nerve itself can be injured. So if the nerve's injured, whatever part of the nerve's injured, it won't work anymore. So you can have worse numbness But there are very specific symptoms that correlate with that. And for the patient who has relief from the exacerbating symptoms, but still baseline numbness that's unchanged from pre-op, that's, in my mind, successful surgery because their function is preserved. They're not generating those pressures on the nerve anymore to damage it, but they just haven't gotten their function back. Does that answer your question?
Yep.
Okay. But in general, it's a very successful operation. Other ways of doing this surgery, so you can do a big open surgery, cut it from here to here. For when I do revise the carpal tunnels for people who have carpal tunnel surgery to come back or their nerve needs to be explored for other reasons, my incision is much bigger if they've had previous surgery. It's from here to there, mainly because I want to find the nerve in virgin territory, because once you've operated on someplace, there's scarring in place, and so that your normal anatomic landmarks are not as visible. And so you want to trace the nerve from an area that's normal into the scar so you can safely dissect it free. Another way to do carpal tunnel release is endoscopically, and that often involves either an incision right here at the base of your palm and another one over here, or just one right there. And you do it with a camera, and you're essentially doing the same surgery as this open one. It's just that the skin is not cut over here, but all the soft tissues underneath get cut with looking through a camera. I don't do that procedure, one, because I wasn't trained to do it, and two, there's really no difference in terms of outcomes. I mean, some patients, the draw to it is the thought that, oh, you recover faster, but the literature really hasn't borne that out. I had some people who were mentors to me when I was in training, and they did their fellowship and with attendings or their bosses that did endoscopic, and they'd sit them in the office, and sometimes patients had problems, or sometimes this finger here could be more numb than before, just because of the way of the shape of the guide and how you do it. You can kind of damage one of those nerves or press on it. And to me, it's not, and for my hands, it's just not really worth the risk of doing, and it's a bigger setup in the OR. I can do the surgery in 15 minutes. Endoscopic one takes a little bit more time, but for the people who do it and have done a lot of them, they can do it safely and effectively, and if that's the way they do it and they're comfortable doing it, there's absolutely nothing wrong with it. The results tend to be the same, but for me, it's just not how I do it, and then in the long term, it doesn't really make much of a difference how I do it.
Camera?
Yeah, as long as the ligament's cut. But it's perfectly acceptable to do it that way. And some patients find that attractive, just a smaller scar and stuff like that. But even with a big incision here, I had one attending a fellowship who would do his normal carpal tunnels with incision from here to here. They hand scars incredibly well. And a year after the surgery, you could barely find the scar anyway. All right, so I'm going to move on to distal radius fractures. Does anybody have any questions about carpal tunnel syndrome? I think I talked ad nauseum about that. I see like 10 people a day with it. Any questions at all?
Yeah, we get about 10 EMGs.
Yeah. So distal radius fractures. This is a very common fracture. It's one of the most common fractures of the upper extremity.
I've got to leave.
Take care of yourself.
Thank you very much.
No problem. It's 7 o'clock already. All right, well, I'll run through this really quickly. I don't want to keep people here. So the radius bone is right here. So this is, again, a picture of here's your wrist, and here's your radius bone right there, and this is your ulna. This is an example of a fractured one. You see the difference between that one and that one? You see that there? And so this is just a cartoon drawing of some of the different types of fractures. And so in general, there are extra-articular fractures, or articular refers to a joint where the cartilage is. So extra outside of the joint. And so here's a fracture, and here's the joint surface, so it's outside of the joint. And sometimes you can have fractures that go into the joint, like this. Okay, and so both of these are examples of non-displaced fractures. So the fracture fragments are not blown apart, they're not spread apart. They're well lined up. These kinds of injuries tend to be from low energy injuries. So the injuries don't impart a lot of force on them. High energy injuries tend to displace the fractures. Also, the patient's bone quality comes into play here. So if you have strong bones and you have a low energy injury, you're more apt to have a non-displaced fracture. But if you have weak bones, all bets are off. You can have a low energy injury, but your distal radius can be blown up. Or you can have a high energy injury and it's like completely dusted. And so these are examples of displaced fractures. You see how the fragments are not together anymore. So when you have these fractures, they hurt. Sometimes the wrist is deformed. It looks funny, like a dinner fork. It's in a Z. And so patients often go to the ER for these things. Some people don't, but most do. So sometimes when you go to the ER, if they're displaced, you'll get what's called a reduction maneuver in the emergency room, with appropriate pain control and sedation, whether either an orthopedic surgeon or the ER doctor will manipulate the bones back into place so that they're better aligned. And sometimes you can do it so that they're anatomic, so that they're very well lined up, and that's all you have to do. And then you put a splint on to hold the bones in place while they heal. And so an example of that is right here. So here's a fracture. So this is the lateral. You can see how the articular surface is tilted back. So here's the back of the hand, here's the front of the hand, and it's bent backwards. And normally this surface here is actually bent forward a little bit. And here's another image of that same picture. You can see how it's kind of smushed down. You can see all the fracture lines in there. And so a reduction maneuver was performed for this fracture, and the reduction was actually really good. You can see the difference. This is an anatomic reduction, which is very unusual for fractures that are manually reduced. It's very difficult to do this, and the vast majority of them will not reduce this well. And it has nothing to do with the skill of the person who's doing it. It just has to do with the nature of the fracture. Sometimes they come together, and sometimes they're just so damaged that you just can't get them where you want them to be. But for this instance, this particular patient was able to be treated with this splint, and everything stayed. Things didn't displace. So sometimes you can reduce them in a good position, get an X-ray a week later, and it's fallen back. It's displaced again. And again, that's nobody's fault. It's just that that's what the fracture wanted to do. And the splint provides good protection, and it helps to hold things in place, but it's just not perfect. It's not. It's a blunt instrument. It's not a finely tuned instrument to hold things. So sometimes, like I said, splinting is all that's needed, and eventually can be transitioned to a cast, and the bone heals. But sometimes a fracture will displace, or sometimes a fracture is just too bad that you can't reduce it. And do
My
good.
husband had to go
Yeah.
in twice for surgery
Yeah,
because his moved.
yeah, yeah. So that's a reason to potentially pursue surgery. So for non-operative treatment in general, bones heal at about 6 to 8 weeks. And at that point, you can take the cast off or the splint off and start doing range of motion, and just protect with a removable splint. And so, as I said here, that sometimes the reduction is not acceptable, and something needs to be done to make it acceptable. And oftentimes that's surgery. So here's an example of a fracture that was that had surgery to make it better. Reduction was not acceptable, or that it displaced over time. I can't remember which it was. And so here's an example of. I'm sorry, that looks so weird. So here's an example of a plate and screw device. The plate sits on this surface of the bone. You can see that the fracture is, well, trust me, it was anatomically reduced without the distortion from the picture. But you can see the joint surface is leveled out. The height of the radius is restored. You can contrast those pictures to this one. You can see the displacement, and now you can see how it's realigned. And the outcomes with these kinds of things, it's not like the wrist is going to be perfect again. There's a lot of scarring that's involved, and when you have an injury, or a big trauma that's powerful enough to break your bones, there's also a lot of soft tissue damage as well. And that's random trauma. It's not controlled trauma like you would do when you have surgery. It's random trauma with the soft tissue, and so the healing is not as reliable, and sometimes patients have scarring where they can't necessarily flex or extend like they used to, despite realigning the bones. They can't turn their hand over like this as well, or not as well as they used to. But in certain situations where the bones aren't lined up, by realigning the bones, it maximizes the patient's opportunity to have a good outcome. Okay, it might not be perfect, but it would certainly be better than what it would have been if we left it alone. All right. So that's all I have for the raised fractures. Anybody have any questions on that?
How many years of the hardware good for these, when they...
Yeah, so that's an excellent question. So once the bone's healed, the bones start taking all the stress. Okay, and so the hardware is just along for the ride. But if the bones don't heal, the hardware will start to loosen over time. Ever take a paper clip and bend it a lot, and it gets hot and it snaps? The plates that we use work much the same way, except they're designed to last months and months and months, and they're very strong. But what happens if the bones don't heal? The plate sees all this little micro motion, and the plates can eventually break. Now that's very unusual for this kind of fracture, but in general, once the bone heals, which is most of the time, the vast majority of the time, the plates don't fail because they're not seeing that stress anymore. So just leave them. They don't come out unless the patients have problems. Sometimes you can have the tendons can rub on the plate and a facial kind of rupture.
He's got like 3, I think,
Yeah.
here.
Yep, in this form. But the rubbing of the tendons on the plates, that's more from old style plates that had sharp rectangular edges. Nowadays the plates, the edges are very smooth and they're tapered down to kind of like a little hill. So it's a rarer occurrence.
I just have a relative that
Yeah.
had wrist surgery and a plate put in.
Yeah.
And I just got a call today, he's back in the hospital. He was in so much pain, I had to put him back in the hospital.
Yeah, so did you just have surgery?
About maybe 3 weeks ago.
Oh, 3 weeks ago? That could be for a couple of reasons. It could be.
He had an infection.
Oh, yeah. Well, that's what I was about to say. Having an infection can definitely cause pain. I mean, that's one of the complications of, whenever you endeavor upon, something like this, you always have to talk about the potential complications associated with surgery. Infection for that is very rare. It certainly can happen. Yeah. And if it's, certainly that bad from the hospital, it would make sense. You'd probably have another surgery to wash it out, or something like that, or maybe just IV antibiotics. It's hard to say without actually seeing him.
So far away.
Yeah.
Just wondering what caused the infection.
Yeah. Well, it's
It can happen.
yeah, it can happen. Maybe So the problem with metal implants, whether it be total hips, total knees, plates and screws, is that our body can't protect against infection on the plate and screws as well as it can on our native tissue, and so that they can be what's called a nidus for infection. So you can get some bacteria into your bloodstream. We constantly have bacteria in our bloodstream, but most of the time our body clears away. We have little cuts in our mouths, a cut in our hand, from all sorts of places. People who pick their nose can potentially cause bacteria to get into your bloodstream. And for the most part, our body just clears it away. But sometimes if you have an area that's not as well protected, the bacteria can get there and start to grow because our body's defenses can't prevent it. So that's why patients who have a total joint have to have antibiotic prophylaxis before they have dental work. Now joints are.
You even got to go to the dentist and stuff
Yeah.
before they
Yeah, so if you have bad teeth, oftentimes people are encouraged to
get them done.
get them done first before they have their total joints done. Now, joints are especially difficult because the joint surface, in general, your body can't protect well against your normal one, or as well. And so when you put metal and plastic there, it's a potential problem. But plates and screws, it's very rare for that to happen. Very rare. Much more rare than it would for a total joint infection. So oftentimes, if patients have plate and screws, and they don't have antibiotic prophylaxis before dental work or something like that.
I've had screws in my elbow since 1988, never had any trouble
Yeah.
with arthritis.
Yeah.
Yeah, so no problems, but.
All right. Anybody have any other questions? No? All right. Well, I want to thank everybody for coming. It was a pleasure to talk to you guys, and
Very informative.
thanks again.
Thank you.
All right.
Thanks for your time.
No problem.